The next set of developmental disorders are tic disorders. I'll go through the three specific types of tic disorders and diagnostic criteria on the next slide, but I want to introduce what tics are first. A tic is a persistent and involuntary movement or vocalization. There are two types of tics: motor tics, which involve involuntary body movements, such as eye blinking, facial twitches, shoulder shrugging, or hand movements, and vocal tics, which involve any verbal or vocal sound, such as coughing, grunting, barking, or uttering obscenities. You've probably heard of people with tic disorders who uncontrollably swear. This is actually fairly rare, but it does happen. Most tic disorders start fairly early on in life, and as you'll see on the next slide, they begin prior to age of 18. They are again more common among males. Prevalence rates will range from being very rare to as high as about 4% lifetime, depending on the specific type of tic disorder. There are three tic disorders. They are differentiated by the type or types of tics that are present, and by the time duration. So when you are looking to differentiate them, those two pieces of information should be what you pay attention to. The first tic disorder is Tourette syndrome, which is diagnosed when someone has both multiple motor tics and at least one verbal tic. As an example, this is someone who engages in repetitive shoulder shrugging, mouth twitching, and humming. Additionally, their tics must last for over 1 year and start prior to age 18. The next disorder is persistent motor tic disorder or persistent vocal tic disorder. This is when someone has only one category of tic. Either they only have motor tics, in which case they'd be diagnosed with persistent motor tic disorder, or they only have vocal tics, in which case they would be diagnosed with persistent vocal tic disorder. Similar to Tourette syndrome, their tics must last for over 1 year and start prior to age 18. Finally, there's provisional tic disorder. For this diagnosis, the person can have any combination of tics. They can have both vocal and motor tics, or they could have only one type. The main difference between this disorder and the other two is the time duration. These tics, regardless of type, must last for less than 1 year. Again, they must start prior to age 18. So to clarify the differences, Tourette syndrome has both types of tics and lasts over 1 year. Persistent tic disorders involve only one type of tic and last over 1 year. And provisional tic disorder involves any type or types of tics, but lasts less than 1 year. I'd like you to watch the video about kids with Tourette syndrome. I think it gives a really honest look into what this experience is like for these kids, including how it might impact their social functioning, as other kids don't understand why they're engaging in these behaviors. Again, the link to this video will be posted in the handouts. In terms of the etiology, tic disorders are thought to be related to OCD, both because they function similarly and because many people with OCD also have tic disorders. Consequently, at least some of the etiological factors related to OCD are probably relevant to tic disorders, especially the role of negative reinforcement. People with tic disorders often report that when they are about to experience a tic, they feel extreme discomfort or tension. As you heard the little boy in the video talk about, he compared it to needing to sneeze, which most people find fairly uncomfortable. They realize that their tics are embarrassing and they don't want to do them, but they also feel as though they can't hold them in. Doing their tic takes away their feelings of discomfort, in the same way that sneezing takes away our feeling of discomfort. Thus, this works off of negative reinforcement. Engaging in tics removes the negative feelings, so they are more likely to engage in tics in the future when they have the urge to do them. People with tic disorders are sometimes able to successfully inhibit their tics for a brief period of time, when in an environment that necessitates that they'll inhibit them. But then they will often engage in a long string of tics when they have the opportunity to get it out, all of the tics that they inhibited. It's also thought that people with tic disorders may have some deficits in their brain inhibitory mechanisms, and this is responsible for why people with tic disorders have difficulty fully inhibiting these urges. Tics also often become worse when the person is in a social situation in which they are particularly tense or self-conscious, indicating that there is a psychological component to tic disorders that may have to do with evaluation by others. For treatment, medications that are effective for OCD may be somewhat effective for tic disorders. Antipsychotics may also be used because they have shown some utility in decreasing tic behavior. However, The best treatment is habit reversal training, which we discussed when we talked about trichotillomania and excoriation disorder. So remember, people would first be taught to be aware of the early sensations of a tic coming on and the situations in which tics are most likely to happen. Then they are taught relaxation and to engage in incompatible responses. For instance, if my motor tic is to shrug my shoulders, I would be taught to push my shoulders downwards. I cannot shrug them up if I am pushing them down. So once I was aware that I was about to have a tic, I would start pushing my shoulders down while practicing relaxation, which will decrease the tension and discomfort I would experience from withholding my tic. Doing this repeatedly helps the person feel less discomfort when they have the urge to have a tic, which reduces the urge to have a tic since it's not negatively reinforced anymore. Our last category of developmental disorders are elimination disorders. Elimination disorders involve inappropriate elimination of either urine or feces and occur in childhood, though of course we do need to consider developmental level. For example, we wouldn't want to diagnose these two disorders in 2 or even 3-year-olds, who should not be expected to be able to control their bladder consistently. Instead, these disorders are only diagnosed when there is the expectation that elimination control should have been acquired by that point developmentally. The two disorders that we'll discuss are enuresis and encopresis. There's an easy way to remember which disorder corresponds to which elimination problem. Enuresis has a U in it for urine, while encopresis has a P in it for poop. Both of these disorders are more commonly diagnosed in boys. So all of the developmental disorders are more common in boys. The criteria for enuresis is that it involves repeated urination into one's bed or clothes, and this can be done either intentionally or unintentionally. Most often, this is unintentional. The kid frequently wets the bed while sleeping, which is the most common presentation of enuresis. Or the kid has trouble recognizing when his bladder is full and ends up accidentally wetting himself during the day. If it is intentional, it is usually secondary to some other issue like anxiety or defiance. The repeated urination must occur at least twice a week for 3 months if the kid is not otherwise distressed or impaired. This is to rule out this diagnosis in kids with intermittent accidents, but where it's not happening consistently. However, if the kid is distressed about this or impaired, most likely socially, as other kids may make fun of him, or he might not be able to attend sleepovers with friends, then the time duration and frequency does not matter. We can diagnose it even if it is not occurring that often, if there is significant distress or impairment. Importantly, the kid must be at least 5 years old for this diagnosis. The etiology that describes most instances of enuresis, which is accidental bedwetting, has to do with the failure to learn to control one's bladder overnight, or said another way, failure to learn not to automatically empty one's bladder when it becomes full while sleeping. When wetting occurs during the day, whether intentional or unintentional, it is most often related to some stressful event going on in the kid's life, like maybe the kid's parents are getting divorced, and the kid is exhibiting a lot of anxiety or begins behaving defiantly. In terms of treatment, if enuresis was due to stress, the goal of treatment would be to target that cause and work on symptoms of anxiety or defiance. But since the most common presentation of enuresis is due to failure to learn to inhibit bladder emptying overnight, treatment commonly targets that. Essentially, through classical conditioning procedures, the kid needs to learn to wake up when he needs to go to the bathroom so that he doesn't automatically pee while asleep. Right now, the kid's body is failing to process the signal that he has to pee, which should produce the response of him waking up. So instead, he sleeps right through it and pees in his bed. So we need to help the kid learn to produce the response of waking up when he has a full bladder. And we do this by pairing a full bladder with something that will automatically wake the kid up, which tends to be a loud noise. So in this classical conditioning paradigm, the US is an alarm. This produces an automatic response, or a UR, of waking up. Because we don't need to learn to wake up in response to the alarm, that just naturally happens. Instead, what we need to learn is that a full bladder, which is the CS, predicts a loud noise is coming. So we can just go ahead and produce a CR, which is to wake up in response to the full bladder, rather than waiting for the alarm. So parents are encouraged to buy a pad that is laid on the kid's bed and is very sensitive to dampness. Essentially, as soon as the kid starts peeing, the alarm sounds and wakes the kid up. With this repeated experience, the kid's body learns that a full bladder signals a loud noise is coming. So the kid starts being able to wake up on his own in response to the full bladder. This type of treatment can be very effective for bedwetting and enuresis. Medications can also be used, though the conditioning procedure is preferred. Empyramine is one type of medication that can be used, which lessens the soundness or deepness with which the child sleeps. Essentially, it prevents him from entering the deepest stages of sleep, so that the kid may be able to better recognize and wake up when he needs to pee. However, messing with a kid's sleep cycle is not ideal. Another medication is DDAVP, which works by increasing the concentration of the kid's urine, resulting in less volume, so the kid may not need to pee overnight. Since enuresis is the inappropriate passing of urine, encopresis is the inappropriate passage of poop. Again, this must occur repeatedly and can be either intentional or unintentional. Similarly to enuresis, in most cases it is unintentional, though it occurs during the day and not at night. The frequency of this behavior is less than for enuresis. Encopresis can be diagnosed at a frequency of only once a month for 3 months. This diagnosis cannot be given unless the child is at least 4 years old, indicating that children are expected to fully gain good bowel control before having consistent bladder control. Similarly to enuresis, if encopresis is intentional, we would want to determine the underlying cause, which is again likely to be related to stress and defiance issues. But in most cases, encopresis is truly involuntary, and all stems, paradoxically, from constipation. Most of these kids had some experience where pooping was uncomfortable or painful or shameful, so they start withholding their poop. This could be complete withholding, where they don't poop at all for long periods of time, or it could be partial withholding, where they poop a little but don't fully empty. In both cases, poop starts getting backed up and compacted in the intestines. However, the kid keeps eating, which means that poop keeps forming. At some point, the poop has got to go somewhere, so it starts leaking out of the kid. This is actually most commonly how encopresis presents. It's not that you're finding a full-size poop in the kid's pants, but instead it is frequent poop marks and what looks like small amounts of diarrhea in the kid's underwear. Well, so mom observe what looks like the kid is having trouble with diarrhea, because again, that's what it looks like. And so she might do something to try to treat loose stool, like giving the kid Imodium or some other medication to relieve diarrhea. But that's actually the exact opposite of what needs to be done, because the kid is actually super constipated, and medications like Imodium just make the problem worse. So for treatment, the kid needs to completely empty his bowels. In kids with pretty serious cases of encopresis, this likely includes a large dose of laxatives to fully clear the colon and intestines. And then it may necessitate daily enemas, or if less severe, stool softeners, sometimes for months, combined with regularly scheduled poop attempts. Chronic constipation, as seen in encopresis, actually enlarges the kid's intestines and colon, making it difficult for the kid to physically feel when he has to poop. This makes it more likely that the kid will become constipated again, because he can't feel that he needs to poop. So the enemas are necessary to prevent the kid from becoming constipated again while the intestines have time to return to their normal shape. Regular pooping will also assist with this, and the stool softener should make it easy and not painful to poop, so that the kid no longer associates pooping with pain and doesn't start withholding again. We will now move on to discuss the 3 impulse control disorders. Recall that these involve difficulties regulating their behavior, similar to the disruptive behavior disorders. But these disorders can be seen in children and adults. The first disorder is intermittent explosive disorder, which involves difficulty regulating one's aggressive impulses and behaviors. First, the person must demonstrate this failure to control aggressive impulses in one of 2 ways. Either they demonstrate verbal or physical aggression towards property, animals, or other people that does not result in damage, destruction, or harm, but this is done frequently, specifically at least twice a week for 3 months. Or they demonstrate aggression that does result in serious damage, destruction, or physical injury, but it's done infrequently, specifically at least only 3 outbursts within the last 12 months. With regard to the first possibility, where there are frequent outbursts that don't result in tangible damage, this might be someone who frequently yells and screams at others, or who engages in minor physical aggression, like tearing up papers or throwing things that can't break. With regard to the second possibility, where there are infrequent outbursts that do cause damage, This might be someone who punches holes in walls or throws and breaks expensive items, or who punches or otherwise physically harms another person. Importantly, the magnitude of this aggression is grossly out of proportion to the provocation of any stressors precipitating it. What this means is that there's no good reason for the person to get this angry. Something minor happened and the person cannot resist the impulse to exhibit verbal or behavioral aggression. A colleague of mine worked with a man with intermittent explosive disorder who finally decided to engage in treatment following a recent aggressive outburst. His girlfriend had done something really minor, like accidentally burning the dinner she was cooking, and this caused a major outburst. Specifically, the man got so angry that he picked up the TV in their living room and took it outside, throwing it on the windshield of the car he had bought for his girlfriend, causing damage to both the TV and the car. And remember, this was all over the minor event of dinner being burned. It's also important to note that these outbursts are not premeditated or planned ahead of time. They simply happen in the moment when the person cannot control their anger. They are also not committed to achieve some tangible incentive. The person is not destroying property to collect insurance money, and they're not harming another person following a long preparation for how they would get back at them. This is an impulse control disorder, and so importantly, the behavior must be occurring on impulse. Finally, these symptoms must cause distress or impairment, or they are associated with financial or legal consequences, which may be likely to occur as the person may be sued or fired from their job following their behavior. Lastly, the person must be at least 6 years old, as acknowledgement of the fact that little kids are not in control of their emotions or behaviors. Though not part of the diagnostic criteria, it is common that people with intermittent explosive disorder will report feeling physiologically and uncomfortably aroused as they start to experience their anger and aggressive urges. Specifically, they report increase in irregular heart rate, pressure in their head, and body tremors. Engaging in their angry outbursts makes this physical tension go away. Following these episodes, which tend to be fairly brief, the person understands that what they did was wrong. They feel guilty, remorseful, and embarrassed. This is different from people with conduct disorder or antisocial personality disorder, who may destroy property or physically harm others, but they do not feel bad or remorseful afterwards. This disorder is more common among men. Pyromania occurs in individuals who engage in deliberate and purposeful fire setting more than once. Importantly, this will be different than the fire setting we see related to conduct disorder, which is done for the purpose of destroying property. Instead, in pyromania, fire setting is done due to intense fascination with and attraction to fire. They do not wish to harm anyone or specifically destroy property. Instead, they wish to set fire and watch it burn. Similarly to individuals with intermittent explosive disorder, people with pyromania experience physiological arousal and tension when they get the urge to set fires. Once they set the fire, they experience relief from this tension, as well as pleasure and gratification since they are so fascinated with fire. Finally, there are several rule-outs for this disorder to ensure that the fire setting is only being done due to urge to set fires and fascination with fires. The fire setting is explicitly not being done for monetary gain, such as to burn down a house to collect insurance money. It's also not being done as an expression of socio-political ideology. So pyromania is not diagnosed in someone who sets fire to buildings associated with political figures. It's not being done to conceal criminal activity, meaning that the person did not commit a crime in a building and is trying to cover up evidence by burning it down. It's not being done to express anger or vengeance, so the person is not burning down the house of their enemy or to get back at someone. Fire setting is also not being done to improve one's living circumstances, where they would burn down their house so they would need to get a new place to live. Finally, it's not being done in response to psychotic symptoms. For example, they are not hearing auditory hallucinations demanding that they burn down a building. Pyromania is an impulse control disorder, so the fires are set on impulse when the urge arises. However, many people with pyromania will spend considerable time thinking about and planning for fires when the time comes, reflecting their intense interest in fire. For example, they may spend some time thinking about where they could set their next fire, or scoping out abandoned buildings to set fire to. They may spend time getting supplies ready. They may also spend time imagining themselves setting the fire. As I mentioned before, people with pyromania don't want to hurt people from their fire setting. So part of this preparation may include trying to find an abandoned building where the fire setting won't hurt anyone, and also where they will have sufficient time to watch the fire burn after seeing it. This disorder is also more common in men. Finally, our last impulse control disorder is kleptomania. This is diagnosed in people who experience failure to resist impulses to steal items that are not needed for personal use or for monetary value. Importantly, people who steal because they need money or need certain items would not be given this diagnosis, even if they steal repeatedly. Or people who steal things that are not needed but are wanted, like expensive TVs or stereo equipment, but the person doesn't have the money to buy, would also not be given this diagnosis. This diagnosis reflects what we can think of as nonsensical stealing. There does not seem to be a reason for the theft, as the stolen items tend to be trivial or not particularly useful to the person. Thus, the reason for the theft is similar to what we've been talking about for the other disorders. The person experiences an intense urge to steal, accompanied by physiological arousal and tension. Stealing relieves that tension and also produces feelings of pleasure. Similarly to in pyromania, the theft is not occurring to express anger or to seek vengeance, and it's not being done in response to psychotic symptoms. Several years ago now, there were reports in the media concerning several thefts by a well-known celebrity. This was Winona Ryder. It was speculated that she may have been experiencing kleptomania, as she was stealing clothes from the mall, and she clearly had money to pay for them. It's possible that the stealing was occurring due to her irresistible urge to do so. Similarly to intermittent explosive disorder, people with kleptomania understand that their stealing behavior is wrong, and they often feel bad and guilty afterwards. They just can't resist the urge when they experience it. This is the only impulse control disorder that is more common in women. In fact, this is the only disorder in this entire lecture that is more common in women. I'm going to discuss the etiology and treatment for the impulse control disorders together, as they likely share many similar etiological factors. In terms of biological factors, it's thought that people with impulse control disorders have too little serotonin, and they likely inherited high levels of impulsivity. This makes sense, as they are engaging in problematic impulsive behaviors. Negative reinforcement plays a major etiological role as well. Remember that people with these disorders experience that uncomfortable tension and physiological arousal prior to engaging in their impulsive act. Engaging in their impulsive behavior removes that tension. This is similar to what we talked about for tic disorders. Thus, the next time they experience that uncomfortable urge, they're more likely to engage in that behavior again. Thus, negative reinforcement maintains that behavior. Positive reinforcement plays a role too, as the diagnostic criteria even acknowledge that engaging in their impulsive behavior can produce pleasure and gratification. However, negative reinforcement is thought to play the strongest role. Because it is thought that there's too little serotonin, SSRIs can be prescribed to people with impulse control disorders. However, psychological treatments are thought to be more helpful. CBT, in general, can be used to help the person learn alternative strategies to resist their impulses. A specific type of CBT, covert sensitization, is also effective. Recall that we discussed this treatment when we talked about paraphilias. This is the treatment where the person constructs a detailed visualization of them engaging in their behavior, and importantly, being caught and experiencing associated negative emotions like guilt and shame. So related to impulse control disorders, it could be that the person imagines themselves stealing something from a store and getting caught. They imagine themselves being led away to a police car while all the shoppers watch, and the news is relayed to all of their friends and family members. This makes them feel incredibly embarrassed and ashamed. Repeated imagination of this may make them better able to resist engaging in their impulsive acts when the urge occurs, because they have paired the negative emotional experience with the imagined act. Please engage in the What's the Disorder activities for the 3 categories of disorders we discussed in this lecture. Feel free to email me with any questions or to check your answers. So here's the first one. Josh has not been doing well in school since he started kindergarten. He is now in 2nd grade. He has trouble staying on task, is easily distracted, often loses his homework and leaves his coat on the school bus, doesn't finish homework assignments, doesn't pay close attention to his work, and doesn't seem like he's listening when others speak to him. Though this is primarily problematic at school, Josh also has problems at home because he fails to finish his chores and complete his homework. A few times per week, Sadie urinates in her bed while sleeping. This causes Sadie distress, as she is embarrassed and fears that her parents will be angry at her. However, she doesn't wake up until after it has happened and is unable to control it. Charles was recently fired from work. He is a writer at a newspaper and had been having a difficult time controlling himself following feedback on assignments. For instance, when his editor corrected a few grammatical errors, Charles threw a lamp at his editor's computer screen. Another time, he punched a copy editor in the face after the editor attempted to teach him how to appropriately use a semicolon. Charles has been having these outbursts at home as well. When his wife forgot to pick up his dry cleaning, he punched a hole in the wall. This has caused significant problems at work and home for Charles. Over the past year, Michael has gotten into trouble with his parents and with his school on several occasions. He has even been taken to the police station on one occasion. Michael has been very aggressive towards other people, often threatening others and even attempting to stab a student with a knife. Michael has been physically cruel to animals as well, and he has destroyed his friends' belongings purposely. Vinny is a 4-year-old boy who demonstrates problems with developing peer relationships and using nonverbal behaviors, such as making eye contact and appropriate facial expressions. Vinny's language is severely delayed, and he knows only a few words. When he does speak, he often echoes the words that were just said to him. Vinny has deficits in his ability to spontaneously play with others, and instead is preoccupied with certain parts of objects, such as buttons, and can spend hours touching and rotating a button. He does not have any friends and never attempts to engage others in social interaction, including his parents. He additionally becomes alarmingly upset if his routine is altered or delayed. Vinny's parents noticed very early on in his life that he had these deficits. Tammy has persistent involuntary body movements, such as involuntary shoulder shrugs and eye twitches. In addition, Tammy makes involuntary verbal sounds, including shouting obscene words. These involuntary behaviors occur nearly every day and began when Tammy was 8. She is currently 10. During the last school year, Ryan has been exceptionally argumentative and hostile towards his teachers and parents. Specifically, he often argues with adults, deliberately annoys others, blames others for his mistakes, and constantly loses his temper. These symptoms occur at least once a week and have caused him many problems at his middle school, including being suspended. Kim constantly feels the urge to steal things from various locations, including her workplace, the mall, and friends' houses. She has a difficult time controlling this urge, especially because she feels pleasure and relief after stealing something. She has no use for the objects she steals. Instead, she just keeps them in a large box in her basement. Several times per day, Brandon has the urge to scrunch up his nose. He feels as though he needs to engage in this behavior, and if he doesn't, he feels very anxious. At times, people tell Brandon that he is scrunching his nose, though he hasn't realized he has done it. This behavior started approximately 2 years ago. Oliver is 5 years old. For the past 6 months, he has been pooping in his pants while in school. This occurs approximately once a week. Early in childhood, Dustin's parents recognized that his speech and motor development was delayed compared to most kids. He has substantial trouble dressing himself. He cannot tie his shoes. He cannot effectively communicate his needs to others, and his parents are concerned that he will get hurt, if not in a fenced-in yard, because he's likely to run into the street without a second thought. When he entered kindergarten, his teacher noticed this as well. After a cognitive assessment, she informed Dustin's parents that he has an IQ of 60. Tyler has always been fascinated with fire. In his room, he has a large box full of fire-related materials that he looks at every day. He spends his free time searching for old abandoned buildings so that he can set them on fire. He has a feeling of tension and urgency prior to starting fires, which is removed once one is started. He frequently runs away after setting fires and finds a place to hide from which he can watch the fire until it is eventually put out. Throughout the day, Evelyn makes several noises that she experiences as uncontrollable. For example, she will squeak, whistle, and hum at times when it is inappropriate to do so. But she says that she cannot control herself. She also frequently snaps her fingers and repeatedly shrugs her shoulders, which she also experiences as uncontrollable. These symptoms have been occurring for the last 10 months.